Mahipal. Thank you, Dr. Shashi Kapoor. As we all know, the femtosecond laser is an infrared laser, and it works in the principle of generation of a rapidly expanding cloud of free electrons and ionized molecules, which creates a tissue disruption without any collateral damage. Over the years, femtosecond lasers have evolved a lot from the initial early generation days to the current advanced femtosecond lasers. What has changed basically is an increase in the firing frequency from 6 kilohertz to 500 kilohertz. And the refinements include a smaller, more tightly packed cavitation bubbles, which creates an almost continuous cut without any tissue bridges. Also, the suction, which was there initially, the manual suction has now changed into a automated suction. We even have a dual vacuum, which helps us to get better flaps. So these are the commercially available femtosecond lasers today. As you can all see, the basic principle of working of all of them is the same, and they can do much more than flaps. They can do AKs, they can do smile in certain, the Zeiss Visumax can do the smile, and it can also help in pockets and in keratoplasties. So this, I would be talking basically on the FS200, of which I've been using. So this is a small video to demonstrate how we create a flap. So initially, the topographic image is acquired on the topolizer vario. Now this is important because then there's an automated centering of the flap on the visual axis. So having done that, the patient interface is placed on the eye, and each cone can be calibrated before using it. It needs to be calibrated. Now here the first suction is now activated. So there are two suctions, a dual suction. Having activated the first section, the gantry is now lowered until the cornea is applanated. This is entirely under vision. Right up to this stage, you can change the position of the flap. You can move the flap in case you feel that it is not being centered well, though the software automatically manages this. And once the applanation is complete, the suction 2 gets activated. And there's an automated flap centering based on the topolizer vario image. This is now followed with the activation of the femtosecond laser. And it's a very fast procedure, being a 200 Hertz machine. After having the main flap done, the side cuts are completed, and the gantry is raised and the PI is removed from the eye. So basic difference between a microkeratome flap and the femtosecond laser flap is the femtosecond laser is basically a planar flap. It's totally computer controlled. You also have a total visualization of the entire flap making process, and you can adjust and you can make fine changes before you activate the femtosecond laser, which is not possible in the microkeratome flap. Again, buttonholes are hardly seen in a femtosecond laser flap, though they have their unique complications, which I will touch upon later. So basically, real-time visualization and the precision of the flap, the precision as far as the thickness goes, as far as the flap diameter goes, is very, very accurate. Again, these flaps, like I said, are planar and thinner flaps, and what is left behind is a dry and pristine bed, because of which you hit target refraction almost at the first attempt, so the chances of enhancement is very, very low. Again, you get a perfect alignment without any marking. At the end, it just fits in like a manhole cover into the manhole. Fine tuning of the flaps is something which is just not possible with the microkeratome. Here, with the femtosecond flap, you can fine tune the side cut angles, the flap thickness, the diameter, the shape, and the hinge position. The microkeratome flap creates a side cut angle of 60 degrees, whereas a standard femto would create a side cut angle of 90 degrees, where the flap would fit in like a manhole cover. You can also have an acute angle flap that is less than 90 degrees, where the flap locks into place when it comes down, and the relift in these cases is easier. Most commonly nowadays, people are using the reverse cut side cut, where there's 110 to 130 degrees side cut. Here what happens is the edge gets tucked beneath the flap, because of which it causes a better fit. The gutter is much smaller, so much better cosmesis, and reports show that there's less chance of dry eyes because there's an improved severe nerve opposition, causing a less reduction in the corneal sensitivity. Again, the flap thickness of a femtosecond flap can be adjusted from anything between 90 to 130 microns depending on the target refraction and the percentage tissue ablation. The diameter in standard cases are between 9 to 9.5 millimeters, but however you can go smaller in cases of pure spheres where you don't have a cylinder to treat. Again, it's very important to note here that the excimer laser considers the chord length, whereas with the cornea applanated in the femtosecond laser, what you're measuring is the arc length. So the chord length is usually smaller than the arc length, so you need to make allowance for this when you're considering the flap diameter. Again, you can customize the flap depending upon, for this is a case of a pure astigmatism. So we decided to go in for an elliptical flap here so that you don't expose stroma in areas which is not going to be ablated. So basically you get a profile view so you know what is the area which is going to be ablated. You rotate the hinge so that the hinge is not in the way of the ablation. And then the flat axis is enlarged and the opposite axis is now decreased in size. So what you get now is an elliptical flap. So that you can see that entire ablation is occurring within the customized elliptical bed. And with an overlay of the treatment which was planned initially, you see the entire treatment has occurred within the bed which was exposed. So there was no need to expose stroma where you're not going to be ablating. Again, this is the case of myopic astigmatism. A similar sort of strategy is being used. Again, one axis is increased in length. And the other axis is narrowed so that you get an elliptical flap. So this is the first diameter being adjusted. So now what you can see that the entire ablation area, the profile is being matched to the size of the flap, size and shape of the flap. So again, the entire treatment is within the area of the elliptical flap. Again, the hinge position can be adjusted. You can have a nasal hinge. Even if you don't want to change the shape of the flap, you can have either a nasal hinge or a temporal hinge or a customized hinge in cases of a cross axis. So this is a customized hinge for a cylindrical correction. Basic principle here is that you don't want the hinge to get ablated. So you keep the hinge away from the area of the ablation. Now, what is the most beautiful thing of the femtosecond flap is in case of complications. Now here we have a case where one of our fellows was doing this case and there was a decentered flap here. So you see that it was not only decentered, but there was a vacuum break. You can see the vacuum break which is occurring. Side cuts were not complete. Now with a microkeratome, such a flap, you wouldn't be able to go ahead on the same day. But here, after waiting for about an hour or so for the OBL to clear, we redocked this patient. And only thing is we had to go a slightly deeper plane. We went about 20 microns deeper. And on the same day, we could have a proper, the other important thing is the first flap should not be opened. Don't make an attempt to open the first flap. Once you lift the first flap, then you need to postpone the case. There is a little irregularity of the stromal bed, but once the excimer laser is used on that, it gets polished off. So the next day you can hardly make out the first flap which was made. So this is one of the greatest advantages of femtosecond. Again, femtosecond flaps have their own complications like the opaque bubble layer, but this has been reduced over the years with the venting canal which most of the machines are now providing. Again, there are complications like a vertical gas breakthrough. What happens in a vertical gas breakthrough is that the energy is directed anteriorly. Now, because the energy is directed anteriorly, the area of the periphery where the side cut has to occur does not occur, and therefore you have a tissue adhesion over there, and you can't complete the flap like in this case. So we are trying to complete it, but it's not possible. There's a flap, it's totally adhered because the side cut has not occurred, the energy has been directed, and you got a vertical gas breakthrough. So in this case, because the area which was uncut was a very small area, we decided to go ahead and use a crescent blade and complete, because it's a very, very small area, hardly less than a clock hour. Mind you, you can't do this for a large area which is left uncut, because then it would be a totally free cut or a freehand cut and would not be a perfect one. A BCL is important to be used in these cases to prevent any problems with the flap. And this is the post-op picture. Again, DLK is a known complication and can occur in about 10% of the cases. And the other complication which is common in femto flaps is a loss of tissue. It's been seen that there is, in the area between the cut and the uncut area, there is almost a 20 to 80 micron gutter which is never filled with stroma. It is usually filled with an epithelial plug even after 3 months of the procedure. So this is an OCT picture to show that this sort of a thing gets filled up only with an epithelial plug. Again, transient light sensitivity syndrome, also called as good acuity plus photosensitivity. It occurs days to weeks after the femtosecond laser, and it's basically an inflammatory response to the gas bubbles or the biochemical response of the keratocytes to the near infrared laser light. And this can be treated very well with an aggressive steroids. Rainbow glare is something which is a rare complication, and this is because of the micro irregularities on the back surface of the femtosecond flap. And the patient notices colored band of lights radiating from a white light source, usually does not have a visual impact, it is self-limiting. And this was initially described on the intralays and later also by Damien Gattinel on the FS200. So what happens basically is, when you create a femtosecond flap, there's a raster pattern which is created. The raster pattern exists both on the undersurface of the flap and on the stroma. The stromal raster pattern gets polished off with the excimer laser when you do the refractive correction. But the one on the undersurface of the flap remains uncorrected. So there is an irregularity, a raster pattern over there, which is responsible for this rainbow glare. So the treatment for this basically has been described in literature, that what has to be done is you put an eye tracker off, decenter the patient, and treat the undersurface of the flap with a PTK of about 16 to 20 microns in order to polish off the raster pattern. And this usually helps in clearing these rainbow glares. So the disadvantages of femtosecond flaps would be the learning curve, the cost per case, but then one wouldn't want to put a price on the safety. Again, femtosecond lasers in various studies have shown to have a rapid visual acuity, a rapid visual recovery, and a better uncorrected visual acuity. So in conclusion, the ability to fine-tune every aspect of the femto flap is what is the prime concern. Again, it prevents the one-fit-all philosophy, and you can have horses for the courses. But one needs to understand that meticulous planning and understanding of the ablation profile is very important in case you're customizing your flaps. Thank you.